So head injuries in the U.S. are in children are fairly common. Anybody that's worked in our ER or has their own children, you know, kids hit their heads all the time. Fortunately, most of the head injuries that we see, even that make it to neurosurgery or require neurosurgical consultation, aren't anything bad. Severe head injuries in adults tend to be a little more common because adults are more likely to be in high mechanism accidents. Most of the head injuries we see are babies who fall and had skull fractures, and the majority of them are just fine. But it is the leading cause of death in kids who injured themselves. They typically don't die from pelvic fractures like an adult would, or from long bone fractures. They die from their head injury. So this number is actually 17,000. It's probably a little low now. I think it's probably closer to 21,000 kids who end up pretty impaired after a head injury every year. Things like helmets have helped. You know, it's interesting. I just saw who is obvious intellect. The reason I was seeing him is because he has an arachnoid cyst. He has a congenital cyst in his brain, which was found on a head injury, which was found on a CT scan he got after injuring his head on his skateboard without a helmet. So although helmets are much more common than they were, you'd be amazed at what kids do nowadays, even in very highly educated areas that we live in, that aren't really very smart. I always tell kids, whether they've had brain surgery or not, well, for whatever reason, if you're on wheels, you have to wear a helmet, period. The only wheels you don't need to wear a helmet for are a motor vehicle, and arguably you should probably be wearing a helmet there too, but anyway. So 80% of our patients, it's probably about 85%, are mild head injuries. That is, they hit their head and they're perfectly fine. 10% are severe, and those are the ones that we'll focus on a little later. And 10% are moderate. Moderate, you might say, what is a moderate head injury? A moderate head injury is the kid who hits their head and afterwards are awake and alert, but they're just not quite right. They're, you know, sort of the classic kid is the kid I just mentioned. Moderate head injury. They're not comatose, but they're not perfectly fine, and they are cursing. They're using words that parents have never heard. They're combative. They get out of the bed and they refuse to use the restroom and just pee on the floor. They do strange things like that. We don't see that very often, but from time to time we do. With regards to head injuries, assessing a patient, an adult, is pretty easy, and a teenager is pretty easy. Assessing a baby is a little hard. But if you've seen enough babies, it's not that hard. You can look at them and tell them if they're sick or not, even if their fontanelle is closed. So we use GCS, a Glasgow Coma score, all the time. Just as a reminder, the GCS was developed specifically for head injuries. It turns out in the ICU, we use GCS for almost any neurologic evaluation. A kid who's had a stroke, a kid who has hydrocephalus, a kid who had brain tumor surgery, a kid who presents with a pontine glioma. Everybody says their GCS is such and such and such. Well, GCS is really only technically for head injuries. We just tend to use it for other things because it's a common way to communicate what a kid looks like. So I can't ask you guys to raise your hands. If we were doing this live, I would ask the audience to raise their hands or to at least shout out which of the three subcategories of the Glasgow Coma score is most indicative of outcome. In other words, you know, if you had to have a high score in one of these that would determine how well you're going to do, which one would it be? And it would be your motor score. Eye-opening, particularly in a little kid, isn't very helpful. Neither is a verbal score, actually. But motor score is very predictive. If you're following commands, which is the best you can do with regards to a motor score, a score of 6, if you're following commands, you're going to do well, regardless. If you're not following commands, so you may know that Below following commands is localizing pain. So if somebody pinches the kid, or you push on the endotracheal tube and they reach for the tube, it's not quite as good as following commands, but it's the next best. Next is withdrawing to pain, which is pulling your arms up. Next is extending to pain, and then not doing anything. So the higher up that score you are, the better off you're going to be. Getting a verbal score in a teenager and an eye-opening score in a teenager is simple. Doing that in a little kid isn't so. Here, this is just breaking down the motor score, obeying commands, localizing. So abnormal flexion is sort of tucking in the thumbs and bringing up the arms with the legs extended. It's very seldom you see this. Usually they're following commands, localizing the pain, or they're not responsive at all. The in-between stuff isn't so common. A motor score in a kid is, and particularly in a baby, is a little less obvious. But if there's a baby who's fallen and hitting their head and they're squirming around and moving everything, they're probably okay. If they're not doing much and you have to pinch them to get them to localize the pain, it's not very common, but you do see it. I've never seen an infant who abnormally flexes. I have seen, unfortunately, that extends or does nothing. Of course, no movement to pain at all. Making sure that the kid is not cold or there's no narcotics around or paralytics around. If they're not moving to pain, their outcome, regardless of anything, is poor. In an adult, they're going to die. A GCS of 3 in an adult is a fatal, almost uniformly. A GCS of 3 in a kid is not necessarily fatal, because we see the occasional child who comes in with literally fixed and dilated pupils, no response to pain, normal temperature, no narcotics, not opening their eyes. If they're not intubated, they're not saying anything. If they are intubated, of course, you can't get a verbal score, but they have one brainstem reflex. They have, maybe they have an oculovestibular. If you guys know what oculovestibular reflex is, it's a cold caloric. When you put cold water in the ear, if cold water gets on the eardrum, it numbs up the vestibular nerve and it makes the eyes move. So if a child presents to our hospital with a Glasgow Coma score of 3, but has any brainstem reflex, our tendency is to, and they have a surgical lesion, I should say. If they have a subdural or an epidural, our tendency is to operate on them, understanding that their outcome is poor, and if they survive, they'll likely be vegetative. In an adult, regardless of any brainstem reflex, a Glasgow Coma score of 3 is not a surgical candidate, period. In the old days, you could make these decisions on your own. You could see a kid who looks terrible, they're going to do poorly, and you just let them go. There's lots of other, sort of problems with, I wouldn't say problems, but there's other considerations, including, and notwithstanding medical legal ones, with regards to who you decide to operate on and not. So a verbal score in an adult is easy. Do you know where you are? Do you know what day it is? If you don't, maybe you're a little disoriented. If you're spewing out a bunch of expletives and not answering questions, you might be inappropriate. If you're just babbling, incomprehensible, or not speaking at all. Of course, a lot of the patients we see already have an intratracheal tube, so it's hard to get a verbal score, right? A verbal score in a kid obviously is more difficult, but a baby can smile or grimace. If they're crying and you can't console them, it may not be from their head, right? They may have pain, they may have a headache, or they may have another injury. A non-accidental trauma kid may have another fracture or something. And then you can read down the list. We don't need to go through every detail. So the eye-opening score, the teenager with a moderate head injury may close their eyes intentionally, right? You ask them to open their eyes, they don't. You go and you try to open their eyes and they squint them shut. That's pretty good. At least they're aware enough to know to try to keep their eyes closed. Eye-opening score in a kid, either they're open, they open to sound, they open to pain, or they don't open their eyes at all. And again, any one of these scores that has a 1 is just awful. So this is how we typically, this is at least how I traditionally and pretty much in the literature grade head injuries, severe head injuries, moderate, mild. Mild head injuries are essentially normal. They may have a headache. Moderate head injuries are typically a Glasgow coma score that doesn't quite put them in a coma, and a severe head injury usually isn't following commands. It's these kids here, these severe head injuries, that usually end up at least being considered for an intracranial pressure monitor. A patient who follows commands, in my opinion, shouldn't have an ICP monitor. The reason we put in an ICP monitor is because we don't have an exam to follow. And that's the real reason. Of course, we want to know what their pressures are and treat them appropriately, but if we don't have an exam to follow, it's a closed box. During my training, now that was a long time ago, there was actually no evidence in the literature that monitoring intracranial pressure in a kid changes anything, changes their outcome. Since that time, there have been some papers that would imply that indeed it does. I truly believe it does. Our ICU believes it does. So we will consider an ICP monitor if indeed there's a patient in coma and we think it'll help them. And help you guys as well, take care of the baby, take care of the kid. So I'm a surgeon, so we do operate. We don't operate too often for head injuries here. There's much more non-operative head injuries. We don't have a lot of, the 16-year-old who does drive and gets in a car accident, has a subdural, oftentimes ends up in an adult hospital. So a lot of the mechanisms that lead to surgical problems are in older patients who end up in adult institutions, not in ours. So the things that we operate on are subdurals, epidurals, and intracerebral hemorrhages that are actually in the substance of the brain. And once in a while, a kid who has a lot of swelling on one side of the head that's threatening their life without any clots that we will talk about in a moment. So just a quick sort of tutorial on CT scans. Even now for acute trauma, we do CT scans. You'll find that some of our other patients, hydrocephalus patients in particular, who've had many CAT scans, and we want to look at their ventricles in the emergency department, will end up getting a quick or fast MRI. We can now do T2 MRIs in about 3 or 4 minutes, as opposed to an hour to do a brain MRI. But for the acute head injury, particularly when there's a history for trauma, we do a CT scan. Number one, it's quicker, but number two, it allows us to look at the bone. An MR doesn't show the bone very well. CT shows the bone very well. Here's a CT pretty low. These things over here. Hey Cindy, can you see my cursor? Okay. So here's the kid's ears. Front of the head, back of the head.
I don't have an answer for that.
Sorry, that's Siri. She's a moron. Sorry about that. Let me turn her off. Okay, sorry. And I have a male Siri, if you didn't. He's even more annoying. So anyway, so this is the bone. The white stuff is the bone. These are the temporal lobes. These are the frontal lobes. This is the cerebellum, and this is the brainstem. So with the exception of really black stuff, like the air around the head and the air in the sinuses, the dark stuff in the brain is CSF. And the reason I bring that up is because when you see a CT scan, you want to see around the brainstem, you want to see CSF. This is the pons, so this is the prepontine cistern. These are the sylvian fissures. This is all CSF in the little nooks and crannies of the brain. If that stuff goes away, if that stuff gets displaced, the brain is getting pretty swollen. And that's not good, obviously. So this is the fourth ventricle, the prepontine cistern. These are the temporal horns of the lateral ventricles. These are all normal. These are normal, small, nice, small ventricles. This little smiley face here is the paramesencephalic cistern. You always want to see the smiley face. Smiley face goes away, things are getting pretty tight. So, epidural hematomas. Epidural hematomas are between the skull and the dura. So they push the dura into the brain. There's actually no blood on the brain. They're usually arterial in nature. They're usually from a fracture across the middle meningeal artery that tears the artery and it starts to bleed into the epidural space. The classic clinical presentation is a lucid interval. So a kid hits their head. They may hit it hard enough to pass out, but then they wake up and they look pretty good. And then they crump again. They go comatose. And it's because over that period of time, between the time they woke up and the time they go comatose, that clot is getting bigger and bigger and pushing on the brain. This is what happened to
It's Natasha Richardson, right?
Natasha Richardson, yeah. Liam Neeson's wife. She was in a ski accident. She hit her head, and I think she passed out. But anyway, after her head injury, she looked pretty good. She had a headache, and they sort of insisted that she get medical care, and she refused. And then she crumped, and by the time a helicopter came and got her to the hospital, she was dead. She had a big epidural hematoma. So unfortunately, this happens even here. I can't say I've seen it happen in our hospital, but the kid who comes in the emergency room is really busy. The kid looks pretty good. They take the kid in some corner, and somebody comes back and checks on them, and they're dead, or they're comatose, or they're blown a pupil, because over that interval, their epidural's gotten so big. The nice thing about an epidural is they're pretty quick to remove. If a kid has one and they're sick, you can make them better really, really fast. So this is an epidural hematoma. So brain, the white stuff here is skull, but this white stuff is blood. And you can see it's got sort of this lens type appearance. It does this because the dura is getting pushed into the brain rather than blood being on the brain. And most epidurals stop at the sutures. There's a sagittal suture and the coronal suture. They can get really big. And if they're tight enough, they'll pull the dura off the skull and keep crossing a suture. But usually this is what they look like. All you have to do is remove the bone and suck out the clot. Stop whatever's bleeding and you're done. It's a pretty simple, straightforward operation. Subdural hematomas are quite different. Subdural hematomas obviously are under the dura, and there is nothing to keep them from growing. The convexity of the head is pretty big, so a subdural can occupy a huge surface area, and it doesn't need to be very thick for the overall volume to create a lot of pressure on the brain. Subdurals are usually from tearing a vein the veins that go and drain into the midline, superior sagittal sinus. They grow slowly and they are bad news. When blood hits your brain, it is never the same. I'll show you some pictures here. So here is a CT scan again. The white again is the skull. The brain is here. If you see that, you see this white line, that's a little bit of blood between the two hemispheres. This is the midline. So this kid's midline is pushed from the right way over the left. From this is a subdural hematoma. Now this thing has sort of a concave appearance. It doesn't have that lens appearance. It turns out this was a shaken baby, and this black stuff you see here is old blood. So this kid was re-injured. And this subdural goes all the way from here, all the way to up here. And we're only looking at one slice, right? If you go from the top of the head to the bottom of the head with this much blood, that is a lot of blood. That's why there's so much mass effect on this brain. That's why it's so shoved over. This is a picture from surgery from a left-sided craniotomy. So this is the edge of the bone. The bone's been removed. These are little clips on the scalp to keep it from bleeding. I don't use those anymore, incidentally. But this is the dura. This is the covering of the brain. The dura is usually sort of pale and flat. This dura is blue because there's a bunch of blood underneath it, unoxygenated blood. And you can see the nooks and crannies of the brain because it's so swollen it's trying to get out. This is the dura open. And this, you can't tell, this picture is in 2 dimensions, but this brain is like, you know, 2 or 3, probably even more centimeters outside over the surface of the skull. It's just herniating out at us. We had to, and this is all just bloody brain. It looks awful. We had to actually just staple this kid's scalp closed and get him off the table before he died, which he did. Here's some residual subdural blood right here. So an intracerebral hematoma is blood in the brain, like a bruise in your arm. It typically starts off as a contusion. Sometimes it's dark looking, might have a little blood, but then it can blossom. I'll show you what a blossoming contusion looks like. I'll tell you what a contracture is as well. These are kids that if they have a small contusion and they look pretty good, you need to keep a very close eye on them, because if the contusion blossoms into a big hemorrhage, they can get sick and they may need to go to the operating room. And if it goes unnoticed, it can kill them. So here is a kid who had a head injury. This is a big, big contusion in the right frontal lobe and a bit of a contusion in the left frontal lobe. he fell out of a truck. He hit the back of his head, so he's got some blood in the back. But he has a contractile injury. So, he hit the back of his head. His brain sort of fell back and then snapped forward and hit the front of his skull, where underneath the surface of the frontal lobe, the bone is fairly jagged. It just beat the heck out of his frontal lobe. So he got into trouble. My partner this kid I took care of in Cincinnati. My partner at the time took him to the OR and it took out this essentially just dead, beat up brain. So this is what it looked like post-op. You couldn't see his ventricles before, but you can see them here now. But you can see what happened to the contusion on the left. It grew and it blossomed. And he needed to go back to the OR and get that taken out. Here's a kid who had got hit by a bus. I'm sure Cindy's tired of hearing this story, but this kid was went to the store for his mom to get milk, and he never came back. And so his mom went looking for him, and she saw this Metro bus with the kid's bike underneath the front wheel, but without the kid. He had already been taken to the hospital. That's how she found out he got hit by a car. His head was just smashed. You can see these fractures here. This is the bone window of that same CT scan. You see all these bones. Most skull fractures are depressed. That's how they fracture. The skull gets hit and the bone either cracks or gets shoved into the brain. This kid's bones are all coming out the other way, and it's because his brain is so swollen, it's pushing the fractures out. May have saved his life, actually. He did, even though this was his dominant temporal lobe, this is where his speech was, and after surgery and his recovery, he couldn't talk. He ended up doing pretty well and going to college. This is a linear skull fracture. This otherwise looks like a normal brain. You can barely see a little groove right here, but see this fracture? These are a dime a dozen. We see these kids all the time. They invariably do fine and go home. These are babies. They have thin skulls. They fall, they hit their head, they fracture their skull. There's a little bit of, I don't know if I'd call it controversy. It's sort of a medical economic issue about whether these babies should be admitted to the hospital. So baby falls, comes into the ER, there's some swelling, they get a CT scan, they have a skull fracture, the brain looks fine, they look fine. Do they get admitted? Do they go home? Do they stay in observation? Do they stay in observation in the ER? Do they stay in observation on the floor? Do they go to the ICU? Sort of dealer's choice. If the time between the injury and the evaluation is long, like a day, the kid has probably already declared themselves and they can go home. If the injury was an hour or two prior to coming to the emergency department, they should probably be watched. I don't think they necessarily need to be admitted. A little bit has to do with the parents, how comfortable they are, how comfortable the care team is with the parents, what the story is. A lot of these kids, the story isn't necessarily clear, and there's a question of whether there might be some non-accidental trauma. The kid was injured, and they get admitted not for neurosurgical reasons, they get admitted for social CPS reasons. This is a depressed skull fracture from this kid who went flying off his ATV and whacked his head. He fell right down on a trailer hitch, and the hitch shoved this bone into his brain. Yeah, no helmet, right? So that's almost obvious here. And he drove all this. So technically, this doesn't fit into this talk. My talk is about closed head injuries. This kid obviously had a laceration where this thing punctured his skull, punctured his scalp, punctured his skull, and went to his brain. But the reason I show this is just to show you what can happen. Other than the fact that the kid was stupid and wasn't wearing a helmet. But you can see his bone here. You can see both layers of his skull came off in one piece and got shoved into his brain. This is a very dirty, unsterile situation. The point of surgery is not only to take out the bone, but to debride the brain. These kids have to be on antibiotics for a while, so they don't get a brain abscess. Turned out, head usually leave a depressed skull fracture that's quite pointed because of the hoof. But this whole piece of bone got shoved into this kid's brain. Kid actually did fine. The brain underneath looked quite good. Here's the fracture. Looks like you push your thumb into an egg. So these are probably some of the worst head injuries we see. There is no, so you can see a fracture here and a fracture here. This fracture went right through this kid's skull, and this is a black brain. If I'm sorry I didn't point out in the CT scan the difference. This is white matter. I know it looks gray, but we call it white matter on a CT scan. And this is gray matter. You should be able to see the difference between gray and white. It's called gray-white differentiation. That kid that I just showed you with a hypoxic ischemic injury, his brain is essentially black. There is no gray-white differentiation. This is a brain that is anoxic, did not get enough oxygen, and essentially has died, and this kid died. Car accident, stopped breathing at the scene. By the time the paramedics got to him and intubated him, he had had enough time without oxygen to his brain that his brain essentially died. Here's a kid with a diffuse axonal injury. This is almost the opposite. Perfect gray-white differentiation, but the kid's in a coma. Cisterns were open. There's no blood clot. There's nothing. But all these black spots here are little hemorrhages in the brain. This is a shear injury, an axonal injury, where the axons get shorn and can cause coma and can even cause persistent vegetative state just because the head gets shaken so badly. Speaking of which, unfortunately, we need to discuss shaken babies. So for any of you that have worked in a pediatric ICU hours or other, you know that we see a lot of non-accidental trauma. In our hospital, I think we see our fair share of it, unfortunately. A lot of kids die from this, and a lot of kids are abused. And I'll get on my high horse here just for a moment. So we live in a very interesting area, and our hospital takes care of kids from every socioeconomic strata that you can think of, from the poorest to literally the most wealthy. I would urge all of you as ICU nurses to, and listen, this is the pot calling the kettle black. I'm about as judgmental as anybody can be, but don't judge based on how people look, where they come from, what their race is, what their anything is. If you see a child, or if we see a child and a family, and we're concerned about their welfare, it should take less than a trigger to have somebody investigate that. A family, I cared for a kid here who has had a non-accidental trauma. Unless this has changed recently, it's statistically speaking, it's typically daycare worker / nanny, mom or dad's boyfriend, dad, other family member, and the least likely is the mother. So in Virginia, in Maryland, and in DC, I believe all three of those states, unfortunately, unless there's either a witness or somebody confesses to the injury, somebody can't be prosecuted. And that does happen. What will happen is if it's pretty clear that there's no answer as to what happened to the child, they'll be taken out of the home until things are verified to be safe. I saw a kid actually again this week who moved here from this. The family was accused of injuring their child, which from everything I understood they had not, but the media had gotten hold of it. Their lives were so ruined. They had family members in this area, so they just moved here to get away from that. So parents will get upset if they're confronted or they're asked, or there's even any innuendo that they may have hurt their child. How dare you say that I could do that to my child? But that's okay. There's many shaken babies that we never see because they never make it here. If the DC coroner gives a talk, I understand, I haven't seen it, about all the kids that they see who never make it to the hospital because they're they're dead at the scene. And if a kid comes to our emergency room or a hospital and a head injury, a non-accidental head injury is missed, they may be injured again and never make it here. We actually don't know that, right? I'm sorry, I don't mean to sort of pontificate, be so dogmatic, but I think we're all pretty passionate about this sort of stuff. So the neurosurgical issues we see from shaken babies are typically subdurals. We do see skull fractures. Most of the skull fractures we see are actually accidental, not non-accidental. And unfortunately, we see extremity fractures. Retinal hemorrhages are sort of is one of the things that makes the diagnosis of a shaken baby. There's only one other thing that I'm aware of that can cause a retinal hemorrhage. One of the first papers I published many, many years ago as a fellow was regarding this. And that's CPR. Aggressive CPR in a baby can cause bleeding in the retina. Otherwise, it's a shaken baby until proven otherwise. And we see all sorts of terrible fractures and worse. If you haven't worked in the PICU before, some of our experienced PICU nurses will tell you just absolute nightmares about what people do to children, even to little infants, 2 and 3 month old babies. It's just awful. We also see hydrocephalus as a result of a shaken baby. So this is a kid. This is a kid from actually who this is an MRI. Eyeballs. This kid came to see me because she had a big head, and because the pediatrician was following for her big head, and on the next follow-up, she noticed that the kid's eyes she could barely see the eyes because the eyes were closed, but the baby looked fine. And when she went to examine the baby sort of leaned back to look at the doctor because her eyes weren't closed because she couldn't open them. Her eyes were closed because her eyes were so forced down that the pupils were almost buried down into the lower lid. So that is like the extreme of a forced downward gaze, of sunsetting eyes. So she sent her off for an MRI. This is all subdural blood around the temporal lobes, even around the cerebellum. This kid had so much subdural blood that it surrounded the whole brain. For any of you that see babies with big heads, or maybe any of you have babies with big heads, we see kids with big heads all the time who just have enlargement of the subarachnoid spaces. They have too much CSF over their brain. But too much CSF is subarachnoid. This is the arachnoid. This is subdural. This is all blood, old blood. This is why this kid's head is so big. You can see her head is ginormous. And her brain, her poor little brain, has been so compressed that probably a third of her intracranial volume is blood. So this is one of the kids actually that got a pretty big workup, and the family was never found to be, they never found a reason for this kid to have this. So this is a child who comes in. I'd ask you for a raise of hands, or ask you, the audience, is this epidural or subdural? But I'll just tell you that this is subdural, right? So a tremendous amount of shift. The ventricles are shoved way over here. The ventricles should be right here, but they're way over here because of this blood over the right hemisphere. It's not obeying any sutural lines. It's covering the whole hemisphere. It's got this concave appearance, so it is a subdural. And this is a little girl who was shaken, and she came here, and she had but 1 or 2 brainstem reflexes. So I took her to the operating room. There's no parents here. There's nobody here. So knowing that this kid wasn't going to do well, I took her to the OR. So we took out her subdural. Unlike many subdurals, her brain did not swell at us. So I put her bone flap back in. You'll see that sometimes you'll see post-operative kids who are missing their bone flap. Incidentally, just a little teeny little note without being mean. So if a kid comes to the ICU without their bone in, there shouldn't be a sign that says, I have a bone flap. Yes, we all have bone flaps. My bone flap is missing, or I don't have a bone flap. I've probably seen it 10 times. I have a bone flap. Don't do that. So anyway, yes, this kid has a bone flap, but it's in his head, in her head as a little girl. So I put her bone back in because her brain wasn't swollen. As a matter of fact, you see postoperatively, here's an ICP monitor because she's in a coma. Obviously, she had a GCS of 3. We need to monitor to see how her pressure does. And you can see air here between her brain and her skull. So her brain looks pretty good. Her midline shift is much better. But what looks bad is this dark stuff. See how her brain over here looks way different than her brain over here? You can see gray-white differentiation here. You don't see it so well. So her ICP started to go up. She got re-imaged. And now her entire hemisphere is black. Gray-white, excellent. No gray-white, just a black. The air here is gone. Her brain is pushed up against her skull. Her brain is starting to shift again. So she essentially has a big right hemispheric stroke. And it turns out that she stroked out not just because she had a subdural that irritated her brain, but she had a carotid injury. When she was shaken, you know, a lot of these kids are grabbed by the throat. And it doesn't take much to injure the intima of the carotid artery, and they dissect their artery. Blood goes up into the side of the arterial wall rather than through the artery, and they stroke out. So she went back to the operating room, and we took off her skull to allow for her brain to swell out, and you can see how it's swelling out. She survived. You can argue whether that's good or bad. She survived. Her brain atrophied, just sort of shriveled away because it was dead, and we went and put her bone back in. So this is tragic. Seen it over the years many times. This is a retinal hemorrhage. As a matter of fact, this is the fundus. You know, this should all be white with the retina over here, but this is just a billion hemorrhages from the retina just spilling out from a shaken baby. Humerus fracture, femur fracture. Sometimes we see skull fractures that are depressed because the kid's either been struck with something, or unfortunately sometimes they're swung into a wall or into a table or something. They're held by their feet and they're swung. And I've seen even a couple kids who have the little ties for ponytails and pigtails that have little balls on them, where it hits up against the wall and it drives it into the skull. It's remarkable, right, that people do this to kids, but they do. I don't think there's enough pain for these people on the planet. But anyway, those are my personal feelings. So we do see kids, as I mentioned earlier, with large collections outside of their brain, and if they come from a place where the radiology isn't particularly good, somebody might say they're subdural hematomas. They're not. They're just large subarachnoid spaces. I was mentioning earlier that kids get subdurals because they tear these veins right here that drain blood from the brain into the superior sagittal sinus. If there's a lot of room between the brain and the dura, the brain may be sort of floating around. And there's a very famous neurosurgeon, actually from this city, who I think still is a hired gun for defense attorneys defending shaken baby, alleged shaken baby defendants. And his argument is that if you have benign enlargement of the subarachnoid space, that the veins are on stretch to begin with, and it doesn't take much for them to tear. Even a kid who's starting to walk and falls and sits on their bottom, that even an incidental trauma like that can cause a subdural hematoma. I think that that's possible. I think it's highly unlikely, but there are perpetrators of shaken babies who've gotten off on that argument. This is a kid who had just that. You see this black stuff? This looks like CSF. It looks just like what we would call benign enlargement of subarachnoid spaces of infancy. But the kid got an MRI, and this black stuff is CSF. This white stuff is blood. Subarachnoid, subdural. Kid comes back, big CPS workup, I don't remember the details, but went home with the parents. I said, you need to come back. We need to get another scan. Comes back, now has this. New blood on the left side in the subdural space. Whole CPS thing gets started up again. Out of the family's custody, comes back with a foster parent, blood's gone. Eventually the kid did fine. Frankly, I don't know what happened in the long run with regards to the parents. We need to recognize it. I'll tell you, our hospital is very good at this. I mean, it's almost McCarthyism here with regards to that. These things rarely go undiagnosed. On morning rounds as a neurosurgery team, we round as a team, and the second the resident or the PA brings up the CT scan from the kid admitted the night before, and there's even a whiff of anything, somebody says, CPS has been called, right? CPS has been called, right? We need to pick it up so these kids don't end up getting killed. Or, you know, arguably, killed is one thing, but vegetative, needing 24-hour care for the rest of their lives is arguably worse. That's the end of my talk. I usually have I have this picture. Here's the thing. We took this picture a long time ago. Suresh was still here. Hassan hadn't come, and now we have a fifth attending, Dan Donahoe. So there's 5 of us. Just Keating and Chima and I are still here, but we have 2 new ones. I would tell you as ICU nurses, I'll exclude myself from the conversation. You know, U.S. News and World Report ranked us number 3 in neurosurgery in the country this year. As far as I'm concerned, we're number 1. Particularly when it comes to our surgical outcomes. I mean, again, I'll exclude myself, but I would let my partners operate. My kids are grown, but operate on my kid any day of the week. They are superb by every measure. We publish frequently. We're on the forefront of pediatric neurosurgery. I think that we take care of babies and children with neurosurgical problems literally as well as anybody on the planet. You should always feel free to call us. You know, there is a pretty straightforward hierarchy and chain of command. But if you see us in the ICU and you want to ask us something, please do, particularly if it's about our patients. But even if it's not, if you're not getting the answer you need from our resident or our PA, you're free to call us. I won't necessarily say that if you call us at 1 in the morning, we're going to be all that happy. Particularly if you've bypassed your own resident, fellow, and attending. But nevertheless, always do the right thing for the kid, and the rest will work out. So I finished a little bit early, but if anybody has any questions, please let me know.
Everybody in the group, if you have a question, go ahead and put it in the chat, and I'll ask it for you. And while you guys are thinking of questions, Dr. Myseros, I'm really glad that you. Well, first, I have heard this talk quite a few times, and it never gets old. It just gets better. And your candor and your care and your obvious, like, palpable compassion and empathy for these kids, and like the level at which you care for them is just like, it's awesome for somebody who has worked at the bedside with you and just like gets to work with you now this way.
Oh,
so first, thank you so much.
I'm a little pale, but I'm blushing.
So when you talked about the hierarchy of like the residents and the PAs, could you explain a little bit how that works in neurosurgery? Because it's a little bit different with, general surgery and our structure, and like if you're working in the
I'm glad you asked, because so this would be a good explanation actually for the other services as well. So our service, as sort of a training place and an academic hospital, we have residents, right? We train residents. Now, unlike the adult hospitals, so neurosurgery residents spend 6 or 7 years in training. They spend 3 or 6 months with us. And they come in at different levels. So their experience level varies, and obviously, as you know from years and years, their abilities in general vary quite a bit, as do their behavior and such. Usually, we have a 3rd or 4th year neurosurgery resident. So their experience with head injury, obviously not pediatric head injury. Our service is run by residents, but also by PAs. Not all the surgical services has PAs. As a matter of fact, even before I came here, neurosurgery had the first PA. Jim Bailey, I think, was the first PA in the hospital. So our PAs, all of them now, have a tremendous amount of experience. Combined experience between the four of them is probably 60 years. I mean, it's a lot. It's a whole lot. So they function at, in my opinion, at a senior resident level, not even a junior resident level. They're very knowledgeable. They, as you may or may not know, they do procedures at the bedside. They put in ICP monitors. They put in EVDs. They put in lumbar drains. They can tap the ventricle. They can tap a subdural. So I would, as being on the other side, I would look at them as a chief resident. And I don't think I'm embellishing at all. I think all of us would agree. They really are excellent by every measure. But they may or may not be on call. On call, and our residents and PAs used to take call from home. That doesn't happen anymore for a number of reasons. So the in-house on-call person will be either a resident or a PA. So if unless you know somebody personally or you run into somebody, call the person on call. That may be a resident or a PA. It could be that person on call, particularly the resident, is in the OR, particularly during the daytime. So you may end up getting the person who's not on call, but you'll get somebody to help you. If they do not respond, talk to your resident, your fellow, your attending, whoever, whatever chain of command you need to follow to get your answer called. But if you're not getting anywhere or something is happening really bad and really fast, just call us or have the operator page us. That should happen. You should have to call an attending in neurosurgery if the system works correctly, once every 5 years. It shouldn't happen very often. But you shouldn't be afraid. I don't know if any of you have seen some of these. I wish I could share it with you. Maybe I will. Some of these YouTube videos about that sort of mimic physicians and neurosurgeons in particular. I will speak for myself. I probably have the shortest temper and the least patience of all of us. Notwithstanding that, call us if you need us. None of that should ever supersede your ability to take care of the kid. Particularly, I mean, if it's, if there's a little blood leaking from a dressing, that can wait. If a kid's blowing a pupil, that cannot wait. You wouldn't have made it this far if you weren't smart enough and intuitive enough to do the jobs that you do. So I'm not worried about that.
Are there any key buzzwords that, and again, these are everybody that's on this line. So we have 114 nurses online, and they're all new to our organization and work in all different units. Is there any key buzzwords that would be good for the newer nurse to know when they do call a resident or a PA if they are really concerned?
So I don't know if there's buzzwords, but there's buzz thoughts. So you shouldn't see CSF from an incision, from a drain. So spinal fluid is like water, right? So you shouldn't see CSF. If you see CSF, say, I see CSF. Because if you see CSF, the kid's going to get meningitis if it's not treated, which can be devastating or fatal. With regards to really acute neurosurgical issues, so a dilated pupil. A child who is awake and alert and talking to you and has a dilated pupil is not herniating. It is impossible. I'm not saying you shouldn't contact somebody about it, but you shouldn't press the code button and call neurosurgery because Joey has an 8mm pupil and he's eating his chicken nuggets, because that kid's not dying. The kid who's comatose, can't wake up, and is dilated a pupil, hit every button you can find, including the neurosurgery one. A sudden drop in blood pressure. So we don't usually see drops in blood pressure that worry us because that's usually from hypovolemia. But if you have a sudden drop in blood pressure in a neurosurgical patient, your concern is that they're not going to get enough oxygen to their brain, and somebody should be alerted. It's hypertension that we worry about more, right? because if the brainstem, the medulla gets squashed, if some kid has a lot of pressure in their head, their sort of physiologic response is to jack their blood pressure up, because they're trying to drive blood into their brain because their blood is hurting, and that's the only thing it can do. And usually, if that happens and it happens acutely enough, the heart rate will drop. So you know the Cushing's response, right? So if you have a drop in the heart rate and an increase in the blood pressure, those are buzzwords. Dilated pupil, CSF, unresponsive. Unresponsive is in the whole neurosurgery world. Unresponsive is a pretty good buzzword.
Okay, I found that very helpful, and I think that that will also I think that should help everybody here. I'd love to just read one note that we had come into the chat before we get off. It says, I'm the manager of clinical education and peri-op. Neurosurgery is the most technically advanced surgery in the OR. The specialty pushes the envelope for advanced procedures in relation to technology. The equipment is very involved, and we have to place an increased level of safety on our neuro procedures. Dr. Myseros is correct. The team is stellar. So thank you so much, Dr. Myseros. And I hope that you